Yeah. So there is now a lot of options that patients have as far as the IOL selection goes. But I think the main thing that we as cataract surgeons are still concentrating on is, 6-6. Can I achieve that 6-6 vision? Where we forget what actually the patient is looking forward to. So we do receive research grant support from Alcon Laboratories. And what do patients really think about their cataract surgery, and what are their wishes that they would like to improve after cataract surgery? And this was a survey done in patients on street and in the clinic of patients with more than 60 years with cataract. And actually majority of the patients said that they would love if they could do their near work without glasses, compared to what we think as 6-6 being our goal of achieving the perfect outcome. The patients are really looking for more near work because many of them are likely to be spending more times indoors, reading, doing phones, etc. With increasing life expectancy, there is also an increase in the period of active life. So people are retiring until now, not retiring until 75, 80, 85, working very actively, doing all their activities on their own, and they don't want to be dependent on anyone and on devices as well. And phones and screens, irrespective of the financial background, irrespective of the city life or urban life, rural, doesn't matter. Phones and screens are taking over for everything. And that's actually our lifeline. If we don't have our phone, we almost feel, robbed of everything in life. So incorporating different kinds of IOLs, particularly the newer generation trifocal IOLs, I think it's important that we customize for each individual. We'll go through some case scenarios. This was our own convent teacher while we were studying in school, now retired English teacher, and you can imagine the impression that all of us would have of a convent teacher. Very strict, very prim, very proper. And now she's presented to us for cataract surgery. Both of her children now stay abroad, one in Europe, one in USA, so they travel a lot, so she likes to travel with her husband. And being a convent teacher, of course, she loves to do Sudoku. So which means near work as well as traveling, which means good distance vision. And therefore, we suggested a bilateral trifocal IOL for her. And fortunately, she did very well. She loves, she's happy to send us her photographs, doing well traveling as well as doing her Sudoku activities. Now, this is probably the proof of the pudding. A very active ophthalmologist, very active into practice and surgery, using progressive glasses, hypermetropic with presbyopia, and has a moderate use of multifocal IOLs in his own practice. So, look at him from a patient perspective. So, he's ophthalmologist, which means microscope and slit lamp most of the times, which means distance vision. Like most of us, he doesn't have a chauffeur. He drives himself home from his clinic back home, which is city driving. He's keen on multifocals IOLs himself, as he has had happy experience of his patients having undergone trifocal IOLs. So having done his ocular profile workup, we found that he's suitable for a bilateral PanOptix IOL. We did a detailed preoperative discussion with him like we would do with any patient. And we explained the possibility of seeing some halos when he drives back home at night. When we did this preoperative workup, what's important to note is that although there was a difference of only 0.3 between the K1 and K2, because it was with the steep axis being vertical, it required a T2, which means you must calculate for all eyes undergoing any form of cataract surgery, but particularly trifocal IOLs, and there is zero tolerance to residual astigmatism. So we went ahead and did a bilateral PanOptix toric in him, and he's extremely happy post-operatively, able to operate, examine, drive, read without any difficulty. He does say that I did observe halos particularly early on, but I would still be very happy to recommend to even all ophthalmic surgeons. So he's in fact volunteered that if any ophthalmic surgeon has a doubt, please, I'll be happy to talk to him and explain to him my experience. So forthright discussion, even in case of medical practitioners or for that matter, ophthalmologists. There's a lot of talk about what's the cutoff value for angle alpha, angle kappa, so on and so forth. But particularly with the newer generation trifocals, there is a very large central bullseye of more than 1.1 millimeters, which means that even if the IOL is little decentered, they are more forgiving. And it would be very, very rare to have an eye with having an angle alpha more than 0.7 or 0.8 and still not have any other abnormality. So they are more forgiving for angle alpha, and probably you need not have to measure that in all cases or in a routine case scenario. This is another interesting case, a 56-year-old male, senior manager in a factory situated in the peripheral zone of the Ahmedabad city. So he drives back home on country roads, which means no street lights, myope since a young age, and he's developed cataract and he has glare. That is his primary concern, because of which he's now not able to drive himself, and he does carpooling with his other employees, which he hates. So his primary concern is glare and night driving. He wants to be independent himself, and therefore trifocal IOL was not suggested to him. And we suggested that bilateral vivity with a target emetropia would be a good option. He will of course need glasses for fine print reading, but at least most of his activities will be taken care of. Post-operatively, he's doing very well. He's driving comfortably on his own, even back home at night. He feels his reading vision is fairly good, and in his day-to-day task of supervising in the factory, he hardly ever needs to use glasses. He's increased his font size and brightness in the phone. That helps him to do his phone as well. He only uses reading glasses selectively while cross-checking bills and accounts at the end of the day, for which he accepts a 1.25 glass for near work. And the fear that we have is that with these modifications on the central optics, will it actually cause internal aberrations coming from the eye? And this is the eye trace of that same patient showing practically no internal aberrations. So the central modifications done on the optic do not affect the quality of vision or the internal aberrations that are created. Another case of a 64-year-old lady, actively does stock market trading. Husband is bedridden, so she takes care of home as well as her husband. Hypermetropia with presbyopia, is keen on spectacle independence but does not want to compromise on quality of vision because she is the only person taking care of everything at home. So we decided we'll go for bilateral vivity toric, target one eye for emetropia and see the outcome and think for the other eye later. She has good distance and reasonably good intermediate and near vision. And for the second eye, normally I would have chosen a 22. We went ahead, discussed a slight mini monovision, and we went ahead and chose a 22.5 diopter for her. So about half a diopter myopic, and she is very comfortable binocularly now even for her near activity. So tweaking the second eye refraction does help to reduce the dependence on near work, although the caveat is that for extreme fine print reading, you will need glasses, like in her case, when she needs to read the expiry dates on the medicines, she does require glasses. 83-year-old female, very fit, very active. Children are in Canada. One son stays here, so 6 months a year she's in Canada. Uses iPad a lot, and she has drusen's in both eyes. So definitely not trifocals, but due to her nuclear cataract, she has very good near vision. So she's not used reading glasses for a very, very long time. We explained to her that trifocal is not a good option, and with Vivity, she may be able to manage her intermediate vision. She is very well post-operatively without glasses for her iPad, and her contrast as well is not affected. And we are in the process of peer reviewing, publishing a study that we have done to evaluate the outcomes of Vivity in patients with dry age-related macular degeneration. And so far, the results have been very encouraging. The visual outcomes for distance, intermediate, and the near add needed is similar to patients having no ARMD or no macular pathology. And the best part is the contrast with and without glare is also not affected. And there are some publications already in literature showing that. So we can probably stretch it even to cases with fine ERMs and dry ARMDs. So I think the newer generation posterior presbyopia correcting IOLs have opened up an avenue of increasing our patient base to which we can offer these wonderful technology that is available. Thank you so much for the patient listening.